Good evening and welcome to the 10th episode of Heart Failure Masterclass by Heart Failure Association of India. This will be the last episode this year, and we'll be starting in March next 2026 after a break of 2 months. So this time also we have the same format. We'll have a presentation by Dr. Ravi Prasad Verma, and then followed by the case presentation. Over to Dr. Venu Gopal for the details of the session and then to take the session forward.
Thank you, Hari. As Dr. Hari Krishnan said, we have two sessions. The first session is a talk on medical statistics, aspiring to for the counterfactual ideal, theoretical basis for the randomization in clinical trials. This will be by Dr. Ravi Prasad Verma, Professor, Achidamanan Center, Sri Chitra Tirunal Institute of Medical Sciences, Trivandrum. Following which we have a case presentation. The case is being presented by Medical College Kottayam, Dr. Chetan and Dr. Paramesh will be presenting this. And the student panel is Dr. Vinay, Dr. Balaram, and Dr. Veer Sangamesh from IMS Hyderabad. So without much ado, let me first welcome Bala to this. Hello.
Hello, can you hear?
Okay.
Welcome.
Okay. Now, so we'll start the program. We'll start the program first with a talk by Dr. Ravi Prasad Verma from Achidamanan Center, Trivandrum. Over to Dr. Verma, please.
Thank you very much for the organizers for giving me this opportunity to share some of my ideas and experience as an epidemiologist. Can I have a feedback? Are my slides visible?
Yeah, it's visible and clear. Your voice is clear. Please go ahead.
Thank you. Thank you for that feedback. I have chosen to use this title, Aspiring for the Counterfactual Ideal, the theoretical basis for randomization in clinical trials. I know it sounds a bit daunting and complex, but it is something we do quite a lot in our research when we do randomized controlled trials. I am trying to shed some light or draw some attention to the theoretical basis on some of the steps that we follow in a randomized controlled trial. I hope the presentation will kind of help me achieve my objective, that is to give a picture of what the counterfactual ideal means and how we aspire for reaching the counterfactual ideal in a randomized controlled trial, the advantages that aspiration offers, and the limitations also, and how this is shaping the way we do clinical trials these days. Let me just talk about a hypothetical person, Raghav, 68 years old, who's a retired school teacher, sedentary, who is overweight with a body mass index of 30 or obese if you want to call it so, has type 2 diabetes mellitus for the past 15 years on metformin, insulin and statins, has a diet that is high in salt and newly diagnosed with a BP reading of 155/92. Now let's move on to another person, again a hypothetical situation, a lady Amala. She's a software professional who's physically active on weekends, but weekdays she's sedentary. She has a BMI of 22. She does not have any comorbidity, but has a history of gestational hypertension 9 years ago. She's not on any medication, has a high caffeine intake, and currently, again, a newly diagnosed hypertensive with a BP reading of 150/95. As we can see, these two people are very different, but both are newly diagnosed as hypertensive. Now, think of a situation where there is a clinical trial for a new drug which has shown some potential as a first-line treatment for hypertension. And we want to do this trial where we compare some people on the drug with some people not on the drug. Okay. Imagine that we are pitching one person giving the drug here. Let us say we are giving the drug to Amala and comparing that person, the response with Raghav. Or think of giving the drug to Raghav and comparing with Amala. That really doesn't help us because they are two very different people. Okay. So what is ideal? We need to compare, like with like. We cannot compare apples with oranges, so to speak. We need comparison of two people who are very similar to each other except for the new treatment. Let me build upon that idea a bit more. A new drug X, we want to test whether it helps in controlling blood pressure in newly diagnosed patients. So we should compare blood pressure in the absence of X to the blood pressure in the presence of X. This is called the counterfactual situation. All other aspects held constant or all else equal. What is the blood pressure in the presence of X compared to the BP in the absence of X? So it involves studying the effect of altering just one factor while everything else remains constant. This is what we mean by the counterfactual situation. It is a very good idea, but very difficult to achieve in real life. If we had parallel universes like the Marvel franchise, where we had the same character in the same universe at the same point in time, then we could achieve the counterfactual situation. Unfortunately, in real life, that is not so. We end up working with people like Raghav and Amala as participants in our studies who can be very different from each other. Therefore, it is a philosophical concept than a reality. This concept is extensively used in many disciplines. I have put two here. One is in economics. In econometrics, there is this concept. It is called ceteris paribus. How do econometricians approach this? They are interested in what is the effect of one variable on the GDP of a country. Investing in women's literacy, everything else kept constant. What effect will it have on the GDP? Investing in health, what effect will it have? Everything else kept constant. Econometricians work with this concept, but with populations. Another discipline that uses this concept is law. They have this concept of sine qua non, without which not. Unlike the econometricians, where this concept is used at population, to compare populations, legal people use it very much at the individual level. It is because of certain reason that the person did something, without which the person would not have done that. The intent to do something or not do something. Everything else kept constant. So law also has this philosophy shaping some of the way they think and work. In epidemiology, we work with groups, sometimes with populations, but mainly with groups, and do group comparisons, not individuals. A counterfactual situation looks like this. On the left side, you can see Raghav with all attributes I had described, and the drug is not given. On the right side, we have Raghav in the exact same situation, but now the drug is given. And we want to find out what is the BP reading now. This is ideal. This is a counterfactual ideal, which is difficult to achieve. Similarly, on the left side, we have Amala with all her attributes without the drug. On the right side, we have Amala with the exact same attitude, all the attributes with the drug. And now we want to know what is her BP. This would be the ideal situation in a clinical trial. I am an epidemiologist. I see people as sheets of data. And this would how the counterfactual data sheet will look like. On one line, on one row, we have Raghav without the treatment. and a certain BP reading. On the next row, we have Raghav with the treatment, all other attributes the same. And I want to know what is the BP reading now. Or I can see that there is one row of Amala with no treatment and a high BP. And if Amala has treatment, what is the BP now? This would be the counterfactual situation that I would like to see. But usually what I see is this. It's quite possible that the person who is receiving the treatment and the control person are very different. There may be so many things that are different. To some extent, we can match same age or plus or minus 2 years, match for sex, match for comorbidity, diabetes. But then again, there will be many variables which are different from one person to the other. Or as a data sheet, I may get something like this where the person receiving the treatment is very different from the person who is the control. We may never achieve the true counterfactual situation in real life. And here we can see that, even if we don't achieve the counterfactual situation, we can ask the question, are we close to the counterfactual situation or are we very far away from it? If you are going to compare Amala with Raghav, I can safely say that we are very far away from the counterfactual situation. Let's give an example, heterogeneity of the cause, differences because one person is on polypharmacy, one person has comorbidities, the other person has some other history. There are so many differences between these two people. And this is the case when we do clinical trials. So is the counterfactual possible or is it only a philosophical concept? In order to understand the counterfactual better, I put an example where this can be achieved, and that is in agriculture. Imagine a field, a large field. On one side, we have the same crop as on the other side. All conditions are same. The type of soil, the watering, the weather, the ambient conditions can be the same. Maybe we can change the pesticide or the fertilizer. We can have fertilizer A on one side and fertilizer B on the other. So yes, the counterfactual is something which can be achieved in certain situations, but in clinical trials, it's difficult to get there. There is a trial that comes close to this. That is the crossover trial. Here we can see that some people are given intervention A and others are given intervention B. After a washout period, they switch. So imagine that I'm the blue shirt with the hands held high person there. I got intervention A for a while. Then after a washout period, I'm getting intervention B. This means that I am comparing myself when I receive intervention A with myself when I'm receiving intervention B. So it does come close to the counterfactual ideal. One variable is different, however, and that is time. And in many situations, we really can't do the crossover trial. We can only do it in relatively safe situations like, skin conditions which are not life-threatening and does not have a serious effect on quality of life. Dry eyes or, dry mouth, something like that where we can have one kind of treatment and then a washout period of 1 week or so, and then the next one. Okay. It depends on the condition, and if it's not very serious, we can try that. But in many of the situations in clinical trials, a crossover study may not be ideal, especially the washout period where people have to be without any treatment. So, how does the randomized control trial, as we know and do it today, aspire for the counterfactual ideal? Instead of working with individuals, we work with groups. We have one group as the control and another group as the intervention. Individuals are going to be very different, but at the group level, the distributions slowly become similar. If we have an adequate sample size, we can aspire for distributional similarity between the control and the intervention group. So the basis for randomization in clinical trial is achieving distributional similarity. And I've tried to show that in this table there, the proportion of women in the control group and the proportion of women in the intervention group, if they are same, good. The mean age and the standard deviation in the control and the intervention, if they are same, very good. Similarly, all the other variables, be it summarized as proportions or means or medians, whatever be the case, if they are comparable in the control and the intervention, I have achieved a situation that is close to the counterfactual ideal. By achieving distributional similarity in the control group and in the intervention group, I have come close to the counterfactual situation. So that is the basis for randomization. Allocation of subjects into 2 or more treatment groups in a way that I get distributional similarity. And it should be done in a way that I cannot predict into which group one person will go, but I can calculate the probability. The whole approach is probabilistic. The probability of a person falling into each group, and based on the data, I can do some statistical analysis to say whether I have achieved distributional similarity. Okay, this is what I've been stressing upon. It is expected to balance both the known and the unknown factors. Here I've listed variables as x01, x02, x03, and so on. x01 I've kept it as the treatment or the control variable, and y as the outcome of interest. There may be other variables that are relevant to this situation, but either I don't know because of my limited knowledge, or I do not have the skills to measure some of the variables. I have the knowledge, I have the skill, but I don't have the logistics to measure some of the variables. But if I have an adequate sample size and a good randomization technique, I can assume that these unknown factors, at least many of them, would also balance out in the intervention and the control group. The adequacy of the sample size is very, very important. So you have to recheck that whether your sample size is adequately powered and the sampling errors, alpha and beta errors, are kept as low as possible so that you can claim distributional similarity. Now, even with adequate sample size and a robust randomization technique, some differences may still happen. Therefore, statistical analysis is required to look at where these differences are, and you can correct for those differences before you make your final comparison. So you do a comparison of the groups at baseline to see whether the distributions are similar. First thing you do is to kind of summarize your variables. Summarize the variable in the intervention group, in the control group. Then compare whether these are similar or not. Our aspiration is similarity. Only then we can claim we have a situation close to the counterfactual ideal. Then, if there are some differences, we can correct for them in multivariate modeling. I put a linear regression equation there where y is the effect of the treatment, the outcome. Alpha is a constant. Beta is the treatment effect of the treatment T1. And x1 indicates the sum of all the the effect of all the covariates plus an error. So this is the linear regression equation. If the outcome is dichotomous, we use the logistic regression and use odds ratios. And if we are having time to event data, then we use the Cox proportional hazard models. So the statistical analysis that we generally do is a correction for distributional differences before we causally link the exposure or the treatment to the outcome that we are observing. So the last 2 or 3 slides. The major flaw in this approach is that we give a lot of importance to the RCT, and the reason for that is we are coming very close to the counterfactual ideal. But we should remember that we are working with the average person. We are not working with individuals. Therefore, we need to think about what is happening at the individual level also. RCT evidence, gold standard evidence, suggests that some treatment may be phenomenally beneficial. But if we give it to some patient, they may not respond, or they may have some problem because of that. And this is becoming increasingly important as health systems move towards financing through insurance. What gets added into the insurance package, one of the criteria is evidence. Market forces are important, but also what we claim as evidence is also important into what gets added to an insurance package. So this is not merely something which is important at the clinical practice level. It's also very important in health policy, increasingly going to be important in the future. So when we say that RCT evidence is gold standard and therefore this treatment has to be included, it's not going to work with everyone. There will be people for whom it doesn't work. And this has been criticized for the past 2-3 decades. And that is why we see another whole crop of outcome measures which are becoming very popular. That is the patient-reported outcome measures and the patient-reported experience measures. I'll put a few examples there. So at present, when we do RCTs, we have the clinical outcome of importance, but sometimes it's a practice to add on the patient experience also so that we get a more holistic view of what is happening. Because finally, the RCT evidence is about what happens to the average person and not exactly what happens to each individual in the study. That's all from my side. Thank you.
Thank you, Ravi, for that very wonderful explanation of this randomization process. I have one question. If you are planning a study for the first time, so a randomized study, so how will you calculate the sample size? Because we don't have any previous experience on that, and you have so many variables. So how will you do that?
So I would approach it in 2 ways. If feasible, I would do a small pilot study, even if it's as small as 10 in each arm. And then I would use that as my basis for computing the sample size for the larger study. If that is not possible, then I would look for analogous interventions with a justification on why I use that as the basis for my sample size. A similar intervention or a similar molecule, this was the effect seen. Then I would use that as the justification. But in the protocol, I would factor in an interim analysis with the possibility of recomputing the sample size once I have finished 50 in each arm or something to see whether my initial computation is sufficient or not.
Second situation is you have done a study which is negative. So are you ethically correct to redo the study with a larger population or not? Or is there any statistical basis for that?
I think I would approach it as a case-by-case basis. Obviously, all studies are not going to be giving a positive result. Let's just talk about the p-value a little bit. It is probability that what we observe is because of chance. I may be adding to the confusion here, but there's a probability for the probability. if I do 100 statistical tests, by chance 5 will be significant. Right. So one study definitely is not going to be the final answer. So then I would have to look at the benefit risk aspect of it. And then if I can claim that another study may be useful, I can. If the risk involved is huge and the benefit is doubtful, then there is an issue. So I think it's more of an ethical, as you rightly said, than a statistical issue.
Thank you, Ravi. Any other comments or questions?
Yeah, Dr. Ravi, this is Dr. Balachandar. I just wanted to know what is the current role of this decentralized clinical trials, DCTs we call it. How often we can use it in the clinical scenario?
I'm sorry, sir. I'm unaware of that term, so I
So
apologize.
they use this method to using either technical things like wearables and other things, but they call it one is patient-centric, the other is decentralized clinical trials. So I thought was some recent advance which we can incorporate in the clinical trials. Of course, this is
I have not come across that in epidemiological theory.
okay.
I believe it's probably more of a logistical way that clinical trials can be done closer to people's lives where they are rather than in an institution. Because when you mentioned wearable, that is the thought that crossed my mind.
Okay.
But I will go back and read up on that. So that's very interesting point. I think I'll definitely go and check on that.
I have one question.
No.
Devi, thing is, you said as the sample size increases, the anomalies tend to become lesser and lesser between the two groups. Suppose you have a small group, but with much more commonality between them. Which is better?
A tricky question. Okay.
No,
But
I agree that's it's a
yeah.
hypothetical question.
Yeah, for
I just
me,
wanted to ask you about that.
so there are, for me, I would have two levels of thinking. So if I have commonalities, I don't have to struggle with the multivariate analysis. So I'll be happy in the implementation part. What I do with the data is easier to interpret because I have the commonality. Then my doubt would be, as an epidemiologist, I will ask whether there is any selection bias. Okay. Why? Because I expect a lot of variation from person to person. So why am I not seeing this variation? Is it because all the people coming to this hospital or this setting is of the same kind? Or is it because of stringent selection or exclusion that I ended up having a same kind of group? So I would be critical of myself at that level. But when I actually do the analysis, I'll be quite happy to proceed by discussing the findings, saying that the distributions were similar even at a smaller sample size.
Because many of the studies, there has been comment that the groups compared are too similar. So the relevance or the interpretation may not be very, very accurate. That is why I just asked you that question.
Now FDA has mandated more and more patient-centric outcomes as one of the major components for giving approval rather than RCTs. Now patients, all these quality of life scores have become very important, and FDA is mandated that has to be there.
So in that concept only I was asking. One is patient-centric. It's very important.
Yeah.
And the second is decentralized.
Okay.
Most of the studies, we don't get the post-market surveillance usually is not brought in at all. We are only seeing the study results. Probably that also would be very, very important in future.
Yeah. Okay, so we'll move to the next.
Okay, thank you very much for an excellent.
Thank you, Ravi. Yeah.
Thank you for the
I
opportunity.
enjoyed it. Thank you so much. Can we go to the next part of the program? That's a case presentation. The case is being presented by students from Kottayam Medical College.
Dr. Rehyanath, welcome
Has
to
she
the.
joined?
She has joined. Yeah.
Okay. She's muted and not visible.
Yeah, she's.
Okay. Okay. So can we have the student panel from Kottayam Medical College to start presenting their case?
Yes.
And the participating students are from NIMS Hyderabad. So
Yeah.
let's go to the case presentation. Dr. Paramesh is presenting the case, is it?
Yes.
And sir, can you introduce the examiners
Oh,
also?
sorry, I forgot to introduce the examiners. We have a very, very distinguished panel of examiners. Both are my close friends also. Dr. Dayasagar Rao is one of the senior most teachers in the country in clinical cardiology. He is in charge of he is the cardiologist in charge of the KIMS Hospital, Hyderabad. Dr. J. Balachandar was former director and professor of cardiology at JIPMER Pondicherry. And he's also somebody whom I have been knowing for a very, very long time. Dr. Rahianath is the third examiner. She is the professor and head of the Department of Cardiology at Medical College, Kottayam. So over to the examiners and the student panel for the case presentation. Dr. Paramesh.
Sir, okay. So good evening, sir. We'll be presenting the case presentation for today. Coming to this is about a 40-year-old female. The chief complaints are palpitations for 7 years, dyspnea for the past 5 years, abdominal distension for 1 year, and pedal edema for the past 1 year. Coming to the history of presenting illness, the patient noticed to have palpitations gradually progressing from NYHA function class 2 to NYHA function class 4 over the past 7 years. The palpitations were gradual in onset and offset, initially regular in rhythm. However, since the past 3 years, she seems to have felt the palpitations are irregular in rhythm. She also complains of dyspnea since 5 years, gradually progressing from NYHA functional class 2 to functional class 4 over the 5 years. There is no history of episodes of PND or orthopnea. She also complains of abdominal distension and pedal edema over the past 1 year. Abdominal distension preceded pedal edema by approximately 1 month. It was also associated with the symptoms of early satiety and fatigue. There are no history of chest pain, pre-syncope, syncope, post-palpitation diuresis, hemoptysis, or fever. Coming to the past history, she was born as the third child of a non-consanguineous marriage. She had recurrent respiratory tract infections in childhood. She was detected to have a heart disease when she was admitted with pneumonia in a nearby hospital. Evaluation and she was referred to a tertiary care center for its evaluation. Evaluation was done from there and she was advised to follow up. But however, she was lost to follow up after the initial evaluation. By the age of 20 years, she developed symptoms of exertional palpitations and dyspnea and underwent surgery at the age of 23 years through midline sternotomy. She was asymptomatic after discharge and was on regular follow-up. After 10 years of surgery at the age of 30 years, at the age of 33 years, she again started to have palpitations, which was NYHA functional class 3, and was told that she requires another surgery. So coming to personal history, there are no relevant personal history. Menstrual and obstetric history. She attained menarche at the age of 13 years. Regular cycles. There are 2 uneventful normal deliveries at the age of 27 years and 30 years. Socioeconomic history. She belongs to a lower socioeconomic group. Lives in a Paka house. The treatment history. After surgery in 2008, she was not on any regular medications. From the past 7 years, she's on diuretics and beta blockers. Coming to family history, she's the third child of a non-consanguineous marriage. No history of cardiac disease in parents or first-degree relatives. So, summarizing, a 40-year-old female with a childhood history of recurrent respiratory tract infections, diagnosed to have a heart disease at the age of 3 years, was asymptomatic till 20 years of age, underwent surgery for the same at the age of 23 years due to palpitation and dyspnea by midline sternotomy, with recurrence of the similar symptoms after 10 years, and was advised in another surgery. Now comes with complaints of palpitation, dyspnea, abdominal distension, and pedal edema.
Actually, Dr. Rao is there. Dr. Dayasagar Rao, is he here? Okay. See, the problem is when you are presenting a history at the DM level, you don't have to go with the traditional method of presenting symptoms and then go to past history because it doesn't give a complete picture. For example, let me tell you in this case, the patient has had recurrent respiratory tract infection from childhood, and then she was asymptomatic. Then she underwent surgery, and then she had possible another surgery was advised, and then all these symptoms have developed. So if you had put this whole thing as a chronological event, it would have given us a better picture of what we are dealing. Because if you just say palpitations and then the patient goes into a heart failure like symptom, then we would think of, tachycardiomyopathy or something like that. But then you have added on in the past history uh, the surgery which is the patient has undergone, and also brought in a recurrent respiratory tract infection since childhood. So all this has gone back and forth. So this sort of thing may, some examiners may like to have it as a complete chronological event, even if in telegraphic language, that recurrent respiratory tract infection, then surgery, and then so that would be the method of presentation, especially if the time is short in your examination. This would be much better than sticking to the traditional of present illness, past illness, family history, etc. Dr. Rao is
Yeah,
there?
I'm here. I think
Good.
probably what you said is more appropriate. It does give you what has happened, what could be the any heart disease starting at the age of 3 years, more likely to be a congenital heart disease, and then had surgery. Following surgery, she was okay for 10 years. Then she developed a problem, either related to the heart disease or to the previous illness, or maybe occurrence of a new disease, which really precipitated the present event. So I just wanted to ask the candidate, does she have a heart, what kind of heart disease are they expecting based on this history?
So at the age of 3 years, she had a recurrent respiratory tract infection. So probably a left to right shunt at a post tricuspid level.
Why do you say post-tricuspid level?
Usually pre-tricuspid shunts don't manifest with such symptoms at the age of 3 years, unless there are additional shunts.
Like?
Maybe at the mixed levels, pre-tricuspid, post-tricuspid, and arterial level, or usually post-tricuspid shunts like VSD and PDA are the major causes of such symptoms, and the patient will be diagnosed at a young age.
Suppose if a pre-tricuspid shunt presents like this, what should you think in addition to the pre-tricuspid shunt? Or what makes the shunt more large in the presence of what type of diseases?
If
Agreed
the
that
patient
straightforward simple ASD unlikely to present with a lot of problems at a very early age or in the first decade. But should they develop symptoms in the first decade with a pre-tricuspid shunt, we should think of other associated conditions which will make the shunt more large. You have understood the question?
Which pre-tricuspid shunts like ASD are associated with problems in the first trial?
Or what you think as an ASD is not really ASD, something else.
Not really ASD, correct.
maybe
Shunted multiple levels like AV canal defects might be a possibility.
I think we can ask the questions to the other group of
A
students.
student panel from the NIMS.
Yes.
Or the student panel is there in the NIMS?
Yes.
Yes, sir.
Yeah.
Yes.
The ASD associated with any obstructive lesions like MS or any AS, aortic stenosis, or any coarctation of aorta, it will worsen the shunt from left to right shunt, sir. Like Lutembecker syndrome in MS. And
So in short, it must be a left-sided obstructions.
Yes, sir.
Additional left-sided disease when you get a shunt, very large shunt at a very early age.
Yes.
Okay. Anything else?
There's one question just off track.
Yeah.
What is an obligatory shunt in an AVSD or an atrioventricular septal defect? What shunt is obligatory there? In the AVSD, atrioventricular or AV canal, what is the shunt which makes it quite large and goes into RA?
Inlet VSD.
All right. See, it could be due to MR, then going into LA, then going into RA as a left to right shunt. It could be a direct shunt through an AVSD from the LV to RA, isn't it? So that shunt is an obligatory shunt as far as AVSD is concerned. Okay.
Could this also be due to what we call TAPVC or some variant of anomalous pulmonary venous connection presenting with symptoms at a very early age?
ASD can have associated partial AV canal, partial connection, partial venous connection, sir. That can also increase the shunt, the left to right shunt.
No, what I'm talking about is not partial, but total anomalous.
With abnormal streaming into the LA.
Sorry, what did you say?
With abnormal streaming into the LA.
Pulmonary veins are supposed to drain to the LA only. So basically now we are thinking of a large shunt with no obvious cause. What looks clinically like an ASD. So that is one of the things to be suspected.
Obstruction.
TAPVC.
Yeah.
No, TAPVC, that's what I said. What kind of TAPVC at the age of 3 years?
If obstructive, if the shunt becomes restrictive, then signs of obstruction can happen.
That is very early, right?
That is childhood, infancy.
Infancy. This is, she has become symptomatic at the age of 3 years. From the history at least.
So, development of PH.
Okay, a large shunt, Are there any? Okay, go ahead. What are the other possibilities? One is left-sided heart disease, which was not suspected. Other one is total anomalous pulmonary venous connection. Anything else?
Also, most likely it will be it's a congenital heart disease only. So.
Okay. Go ahead. Any other possibilities if you have? Otherwise,
Yes,
we'll go on to.
There's an additional slide which I have made, sir. Possible diagnosis. So, sir, at the age of 3 years, possibilities are what I have considered are post-tricuspid shunt lesions like left to right shunts like a VSD and PDA, then shunt at multiple levels, AV canal defect. Mostly partial AV canal defect because complete AV canal defect can go into early Eisenmenger at a very early age, less than 1 year. And the possibility at the age of 23 is why she required a surgery for the same at that age and not at the age of 3 years. Might be a surgery for a VSD correction with the patient might be having an associated AR, and she might have undergone a surgery for VSD correction with a probable aortic valve repair. Or if you are considering partial AV canal defect, then partial AV canal defect closure with mitral valve repair for cleft AML. And at the age of 30 years, again, she had a recurrence of symptoms. So I'm considering the possibility of a residual shunt lesion or progression of a valvular heart disease like a AR or MR. And the current symptoms are attributable maybe those are definitely looking like a right heart failure symptoms, maybe secondary to PAH, or remote possibility is a post pericardiotomy constrictive pericarditis like picture.
Sure, go ahead. I think there are
Okay.
possibilities. We will go step by step. So, can we have the physical findings?
Yes, sir. So coming to the examination, general physical examination, she's a moderately built and poorly nourished lady, height of 150 centimeter, weight 40 kg, BMI of 17.7, arm span 148 centimeter, arm span by height is 0.99 and upper segment by lower segment ratio of 0.95. Icterus is present, bilateral pitting pedal edema is present. There are no pallor sinuses, clubbing or lymphadenopathy. Coming to pulse, pulse is 130 beats per minute, irregularly irregular, varying volume, predominantly low volume, normal in character, condition of vessel wall normal, no radial or radiofemoral delay. All peripheral pulsations are palpable equally bilaterally, and the pulse affects deficit is 20. BP of right upper limb is 94/60, left upper limb is 90/60, and systolic BP of right lower limb is 104. The JVP is elevated. Upper level of JVP is not visible in upright position and on inspiration. There are prominent V waves and rapid Y descent is present, and A waves are absent. Gardner sign and Mays sign is positive. Patient is febrile. Respiratory rate is 24 per minute. Thoracoabdominal and SpO2 is 97% in all four limbs.
Are you breathing room air or?
In room air, sir.
Yep.
Okay.
This is the image of our JVP. There are prominent V waves, irregular rhythm. A waves are seem to be absent.
How did you arrive that it is a V wave?
So I have timed it with the sound, first heart sound. Sir.
No, but in a patient with atrial fibrillation,
In AF,
there can't be any other wave.
Yes, sir.
Okay, and it is irregular.
Yes, sir.
It's in atrial fibrillation.
Yes, sir. Yes.
Okay, so this is a patient what looks like a corrected congenital heart disease, right? So at the age of 23, which congenital heart disease can cause this kind of a atrial fibrillation with fast ventricular rate? Is it a consequence of the surgery, or is it a consequence of the natural history of the disease? Or was there anything else which made atrial fibrillation more likely?
It's a cause of the disease itself, sir.
The cause of the disease means it is tachycardia myopathy now, you're telling? Patient underwent surgery, probably for the what you call congenital heart defect. Then, is it common to develop atrial fibrillation in patients post-op VSD and PDA?
Yes, sir.
Is it common?
no.
Immediate post-op period.
Not immediate post-op. This is,
Quite a
we are talking about at the age of 30 years now.
Not.
What are the long-term consequences of ASD? Uncorrected.
Tyson mineralization,
Eisenmenger is very common with ASD. It's least common.
with VSD and
No, we are talking about a congenital heart disease developing post-operatively, and then 10 years down the line, you have got a patient who is in atrial fibrillation at the age of 30. Which shunt is more likely? ASD, VSD, PDA?
ASD is likely, sir.
ASD is more likely. Okay.
Yeah, before we proceed, just for the sake, other people's sake, you use two terms. One is called Gartner's sign, one is May sign. Can you just explain for the others what is Gartner's sign? Why did we use it here?
Yes, Gardner sign is the we didn't get any the whatever pulsation we have
level.
seen in the neck. It was the external jugular vein pulsation, sir.
Okay.
We couldn't get the upper level of IJV. So in such cases, to see whether the systemic venous pressure is truly elevated, two signs are useful: Gardner sign and May sign. Gardner sign is will ask the patient to raise their arm above the heart level. Usually, at the at above the heart level, the dorsal veins of the hands usually they will collapse. If the systemic venous pressure is elevated, it will remain filled. The May sign is abnormal prominence of lingual veins on the surface of the tongue.
Now,
Okay.
what does how does that help in diagnosis?
So if the JBP is not visible, the upper level is
No,
not
it is
visible.
actually external jugular vein is distended and pulsatile.
Yes, sir.
So venous pressure is elevated.
Yes, sir.
So
If,
venous pressure is elevated, then beyond that, you cannot make out anything out of the venous pulse.
yes.
The only other thing is it falling with inspiration or not falling with inspiration?
That's important.
You didn't mention that.
That is important, whether it's falling with inspiration or not. And
it was
since
not.
you are considering some sort of a constriction, whether Kussmaul sign is positive or something like that.
It is not visible with there are no changes with the respiratory cycles, sir. No,
Fine.
it was not inspirations.
Mm-hmm. Can you just show the video again?
Yes.
It is, it is varying. It is varying with respiration. What does the venous pressure fall? What is the normal response of the venous pressure to respiration?
Inspiration, it will fall, sir.
Due to?
The intrathoracic pressure becomes more negative.
So
The venous return can RI can accommodate the return of the blood more, so the pressure can fall.
no. When the flow is increasing, how the pressure will fall?
So the pericardial pressure becomes more negative.
It is a transmission of the intrathoracic pressure to the intrapericardial pressures.
RI become more receptive to
No.
blood.
So it becomes more negative. So there's an increase in the flow, and still there is no increase in the pressure. That is on the right side. Is that normal or abnormal?
With the inspiration, there is falling JVP, sir. That's a normal.
That is normal. Okay. So what does that exclude?
CC.
If it's abnormally elevated during inspiration, that indicates whether it's CCP.
No. I'm asking a question. Failure, that the normal fall in the inspiration is there. What conditions you can fairly exclude?
CCP and RCM can.
So restrictive disorders.
Any restriction
RCM.
to filling
restrictive disorders. It is less likely, not that it excludes it, but less likely. Okay, go ahead. What happened? Yeah, because the pulse is irregular, difficult to evaluate the various components. Go ahead.
Coming to the examination of precordium, inspection and palpation. The trachea is central, shape of precordium normal and symmetrical. There is a midline sternotomy scar present. Dilated veins are seen in the upper part of chest and neck. No other visible pulsations or sinuses seen. Apex beat is seen and felt over the left sixth intercostal space, 2 centimeter lateral to mid-clavicular line, diffuse in character, and there is a systolic thrill present at the apex. RV epigastric pulsations are present. There is a grade 3 left parasternal heave. S2 is palpable, and no pulsations in left second intercostal space. Coming to percussion, upper border of liver percussed in the right fifth intercostal space in mid-clavicular line. Tidal percussion is positive. Right heart border is percussed 3 centimeter lateral to right sternal border. second left intercostal space dullness extends 4 centimeter from left sternal border, and lower part of left heart border corresponds to apex. There is dullness in the trough space. Coming to auscultation, S1 is variable intensity,
So
predominantly normal.
before going to auscultation, what have you got so far, which can tell us something about auscultation?
Can you tell us the diagnosis without auscultation?
Yes. The character of apex beat seem to be diffuse.
No, summarize it.
From the
Don't
beginning, yes.
Don't repeat the physical findings. Is there a cardiac disease? Not disease.
Yes, sir. Post-op congenital heart disease.
No, congenital heart disease, we are not sure. But basically now it says, is there a right ventricular disease or a left ventricular disease?
Sir, it seems to be a right ventricular disease.
Is there a pulmonary hypertension present? Not present.
Yes, sir. pH is present.
Then is there a heart failure or no heart failure?
Heart failure is there.
That systolic thrill is there at the apex.
Is there tricuspid regurgitation or not?
Yes, sir.
No, systolic thrill at the apex, did you mention, right?
Yes, sir. Yes, sir.
So systolic thrill at the apex, according to you, is tricuspid regurgitation?
No, sir. Like it is likely mitral regurgitation.
Yes.
Okay. So there is a right heart disease, chronic right heart disease, because there is cardiomegaly. There is evidence of right ventricular hypertrophy. There is evidence of pulmonary hypertension. Probably there is in addition, there is a mitral regurgitation. So these are all the things.
Yes, sir.
Now, does your auscultatory findings confirm or dispute?
Now you can go ahead with the auscultation.
From auscultation, S1 is variable intensity, predominantly normal. S2, wide and variable split is present. A2 normal and P2 is loud. No S3, S4, click or opening snap. Coming to the murmurs, a grade 4/6 high-pitched soft blowing pansystolic murmur is present at the apex, which is conducted to axial and posteriorly, best heard with the diaphragm stethoscope and in expiration. Another murmur, grade 3/6 high-pitched blowing pansystolic murmur heard at lower left sternal border. Carvalho sign is negative. There are no pericardial knock or rub.
Is the liver pulsatile or non-pulsatile?
Yes, sir. Liver is pulsatile.
Didn't mention anywhere.
It is coming. I am mentioning
abdomen.
it in GIT, sir.
Okay. Go ahead.
Respiratory system, upper respiratory tract normal, trachea central, chest symmetrical, moves equally with respiration. Dullness is present over right infraaxial and infrascapular areas. Breath sound intensity decreased over the same areas. Coming to GIT, per abdomen distended, shifting dullness is present. Non-tender hepatomegaly 3 centimeters with soft and smooth edges. Systolic hepatic pulsations are present. Splenomegaly 3 centimeter is present below the left costal margin. CNS and no anomalies detected, and fundoscopy is normal.
Okay, so what is your conclusion based on the physical findings?
So the patient is having RV dysfunction. Patient is in RV failure in AF with a probable mitral regurgitation also.
You don't think there is TR?
Yes, sir. TR is there, sir.
What about pH?
Sir, features of severe pH are there, sir.
So it's a hypertensive TR,
Yes, sir.
pulmonary hypertension, mitral regurgitation. Probable etiology of the mitral regurgitation in this patient?
Maybe it's a associated valvular heart disease with
due to
maybe a partial AV canal defect with cleft AML is a possible.
Surgeon failed to repair it?
Maybe.
You think it's a residual lesion or could it be due to mitral valve prolapse?
It might be a residual lesion.
Might be a residual lesion. Why you are not thinking in terms of mitral valve prolapse? My suspicion is probably patient has got a ASD with mitral valve prolapse, which has progressed and now become more obvious mitral regurgitation. And pulmonary
Examination S1 was normal intensity, sir, and no click was not there, and
S1 normal intensity, what does that tell you?
The valve is the excursion of the mitral valve is normal only, sir. It is not unlike in MVP. It is not.
No.
Excursion is not.
If it is only what we call click is what you are thinking is a normal first sound, maybe a combination of first sound plus a systolic click, mitral valve prolapse. Maybe it is only one of the probabilities. You have said severe MR. What is your criteria to say severe MR clinically?
The character of the apex, LV, if the hyperdynamic apex.
No. What you said was RV
diffuse.
You said RV apex. You didn't say LV.
We heard it as diffuse apex, no? We didn't talk about any lateral retraction or medial retraction.
Yeah, retraction.
There was some cardiomegaly, sir.
No, there's no. It's not a some cardiomegaly. It is a
large
cardiomegaly.
Yes, sir.
Apex beat is in the sixth space in the outside the midclavicular line.
Yes, sir.
So down and out. So what does that signify?
LV might be also enlarged.
Okay.
Dilated LV.
So what are the other criteria for severe MR? One, of course.
At the bedside.
Yes. Wide and
variable test.
No, that can be there due to RBB post-op.
LVS3 can be.
LVS3 will be there.
Is it there?
It is not there, sir.
Is there any short MDM?
No, sir.
Not there. So it doesn't rule out, makes it less likely. Okay. So what is your, you have said acyanotic congenital heart disease. Again, you're telling post-tricuspid. What is your basis to say that?
Just from the history, sir.
This is after history and examination, you know?
Yes, sir.
So what is your basis to say post-tricuspid?
Because of the timing of surgery.
One is the timing of surgery, sir, and I have mentioned probable VSD because the suture, the scar is a midline sternotomy scar. Usually in PDA.
ASD. ASD, how do you do it?
ASD also midline sternotomy.
Then?
So that doesn't differentiate. So
basically now it is all predominant RVH. How common is MR in VSD?
VSD, it is not common, sir.
Not common. So which is more MR is
ASD
more common with the ASD or with the VSD?
Yes, sir. 20% of ASD will have MVP.
Yeah, BP. So basically, now from the history we get the data saying that they have advised another surgery.
What could it be that?
Could it be?
Post ASD repair associated MVP MR and pH.
pH. So what kind of surgery now possible? You know, we still have to see the ECG, X-ray, and 2D echo. But what is the possible cause of MR?
MVP might be one of the possibilities. MVP.
MVP, okay. So it must be severe MR has to demand a valve repair or valve replacement.
Or it could be just, as you said, partial AV canal or ostium primum type.
That is also a possibility, sir.
So, okay, you have written down there acyanotic congenital heart disease post tricuspid. I can only say that probably is the shunt. Severe MR, probably a severe TR. How do you grade the severity of TR at the bedside?
One is the presence of systolic pulsations of liver, sir.
Mm-hmm. So it only tells that it is a hypertensive TR.
Hypertension.
See, this is one of the problems of closing an ASD. Supposing ASD had been closed without paying attention to MR, what would have happened? One, of course, acutely patient can go into pulmonary edema, that is different.
Pulmonary edema, sir.
But chronically, this can occur. Patient can go into a progressive MR, palpitations, and right heart failure, isn't it?
Yes.
So that can occur. So that is what they would have thought, that we can tackle the mitral valve with another surgery. So it might have been ASD closure or even an ostium primum closure, but without paying attention to, or they would have just repaired the cleft mitral valve, but MR would have progressed. Is it possible? What I'm thinking.
Yes, sir. It is possible, sir.
Okay, let's see the ECG. You want to see the ECG or you want to see
Okay.
the X-ray?
I'll go to ECG, sir. It's okay.
How does that help?
If you're considering VSD versus ASD, VSD will usually have a biventricular enlargement in ECGs.
But in a patient with ASD with severe MR, you don't get LVH?
Yes, sir. LVH will be there, sir. Based on the type of ASD, we can the axis of the ECG can also help, sir.
Okay, let's have a look at the ECG. Let's have a look at the ECG.
This is the ECG. ECG showing AF with a fast ventricular rate of approximately 100 beats per minute. There is a right axis deviation, sir.
No, you have to tell us the exact axis.
Exact axis, please.
Yeah. At your level, you are
Axis
supposed
is, yes, sir, 120 plus 120 degrees.
plus 110 degrees. Is it normal or abnormal for a lady of 30 years?
It's abnormal, sir.
Abnormal. So what is the axis like? What do you expect the axis at that age, 30 years? QRS axis.
Normal axis.
And which is what?
0 to 30, negative.
30 to 97.
Minus 30 or plus 30 or?
Minus.
It can't be minus. At the age of 30, it is well below, it is the inferior axis. Based on this QRS axis, do you still think there is AV canal defect?
No, sir.
So what do you think is most likely?
The axis is not plus 120 because AVR is still negative. So it has to be slightly
plus
less than
100,
120.
something like a plus 100.
So it will be 110 or something like that.
Okay. So based on this QRS axis, if at all there is an ASD, what type of ASD do you think it is?
Ostium secundum ASD.
Ostium secundum ASD. Okay, so can this be a VSD based on this ECG?
Biventricular hypertrophy.
Hypertrophy is not seen, sir. Ventricular hypertrophy.
And which ventricular hypertrophy?
LV hypertrophy is not.
Is there a RVH or no RVH?
No RVH.
No RVH, sir.
Totally wrong. What is the axis due to?
What is the axis?
Axis is right axis.
Due to? What is the cause of right axis?
Maybe RVH.
RVH. What is the depth of the S wave in V1? It is very small.
Yes,
It
sir.
generally
You see
said
that
it is generally said that if the S wave in V1 is less than 5,
Yes, sir.
and there is a big S wave in V5, V6, then probably there is no S wave here in V5 and V6, but there is a S wave in V1 is very small in amplitude. Okay,
And
so there
and
is
the
a
frontal plane QRS loop is also clockwise. You have some Q waves in lead 3. So that also shows for RVH.
yeah, it is RVH and no abnormal axis of the QRS. So your AV canal defect is less likely.
Less likely. But
It cannot be what you call excluded. What is the cause of left axis deviation in AV canal defect?
Left ventricular hypertrophy
That is not true.
No, no.
associated severe MR.
No.
No, that is not true. Student panel from the NIMS. Anybody would like to from the student panel?
So what happens to the LVOT?
It becomes elongated, sir.
No, it is supposed to be something like a hyperplasia of the left anterior hemisphere.
Left, so the left anterior fascicular block-like picture occurs, no?
Okay. So based on this ECG, you want to revise your diagnosis? Possible diagnosis?
Second ASD with RV dysfunction and MR.
MR. Okay. Can we have the X-ray?
Yes, sir. So this is the X-ray, X-ray PA view. Cardiomegaly. There's a cardiomegaly with a cardiothoracic ratio of approximately 65%. There is a widened carinal angle, and the chambers enlarged are right atrium, main pulmonary artery, right pulmonary artery, and LA. And
No. Wait. Right pulmonary artery is dilated.
Yes.
What is your criteria?
Criteria for that?
Females we keep it as 15 mm, sir. In males it is 16 mm.
No. You
Where
cannot
from the
measure
branching
it
of the
these
first
things. You cannot measure it. No, you are not measuring it. Any other alternative criteria to say dilatation of the RDPA? You compare it with the diameter of the trachea.
It's trachea.
So if it is bigger than the size of the trachea diameter, then it is dilated. Is there any evidence of pulmonary hypertension in this X-ray? What are the radiological criteria to say PAH?
main pulmonary artery.
No. Main pulmonary artery can also be dilated in so many other conditions, including pulmonic stenosis. So if you're asking,
pruning of the vessels.
Pruning of the vessel is applicable only when there is a left to right shunt.
By RV will be enlarged.
You think that there is any pulmonary venous hypertension here? Because you're talking about severe mitral regurgitation.
Left side, there appears to be some form of cephalization, sir.
What is your criteria to say cephalization?
In the first intercostal space, the width of the vessels should be more than 3 mm.
That is unlikely you measure it. More what do you call practical. When do you say cephalization is present?
Normally, the vascularity of the upper segment will be lesser than the lower segment, basal segment. If it equal or more than that, then cephalization is.
So usually we say cephalization is present only when there is constriction of the lower lobe.
Lower lobe.
So what does that indicate? What is the LA pressure? What is the LA pressure like when there is cephalization?
More than 18, sir. 18.
So what are the other signs of pulmonary venous hypertension on the X-ray? On the X-ray.
Batwing sign will be there, sir.
Batwing sign is a beam end.
Ugly lines, antler sign. reverse mustache
That
sign.
is same thing as
Reverse mustache sign we already said. Cephalitis.
cephalization. Yeah.
Right. Curly A, B, C, and like.
Early lines. Okay.
Interlobar,
The
Fisher
fluid in the
edema
minor.
will be there.
There are 6 signs.
Fisher edema will be there.
Upper lobe venous
Pleural
distension.
effusion.
Upper lobe venous distension. The fluid in the minor fissure. Perihilar haze.
Effusion.
Peribronchial cuffing. Then there is pleural effusion. Then Kerley lines. Out of the 6 signs, how many signs are here?
Pleural effusion is there.
Very good signs.
Very
Three
less.
signs.
3 signs are there.
Okay. Go ahead. So at the end of the ECG and X-ray,
What do you think?
what is your diagnosis?
Probable same diagnosis, sir. Ostium secondum ASD. Now with severe pH, RV failure, and MR.
MR because?
MR because from the ECG there is AF, and from the X-ray there is a widened carinal angle and cephalization, signs of raised LA pressure.
Okay. Let's see the echo.
So these are the echo images. There is a dilated LA, and main pulmonary artery is also seems to be dilated, sir.
Your comment on the mitral valve.
The mitral valve, PML, the mitral valve seems to be thickened, sir.
And
PML.
PML seems to be some.
No. First, what about the AML? AML is normal motion or abnormal motion there? Does it look like a mitral valve prolapse, or does it look like a rheumatic valve?
This is
Anybody
systolic freeze frame, is it? The left side is systolic freeze frame?
No, left-sided one is aortic valve is
Early
closed. Aortic valve is closed. So it's a diastolic frame.
So it can't be gap
Aortic
due to MR, no?
early diastolic.
Yeah, it is not a systolic one. It is diastolic. Certainly
Yeah, correct.
diastolic. LA is mild enlargement or moderate enlargement, or what is the normal size of LA echocardiographically?
Maximum is up to 4.5 centimeters, sir. 3.
Is there any relative value?
In relation to?
What do you take reference point?
Aorta, sir.
Aorta.
Aorta.
So what is the ratio like?
1:1 ratio will be there.
No, it's not 1:1. Certainly not.
Yes.
It is 1.3 times.
Yes.
Here it is, looks like a 3 times the size of aorta. It is not 1. It is not 1.5. It is. So it is a huge dilatation of the LA. Is it common to have LA dilatation with ASD?
ASD, if it associated with Lipton-Becker syndrome, it is.
No.
Still it cannot occur
simple
that much.
ostium secundum ASD. Let us say with mitral valve prolapse. Do you get such a huge dilatation of the LA?
No, sir.
Then?
The pressure will be decompressed by the.
So basically, it is a huge dilatation of the LA, and there is doming of the
AML.
AML. Okay, and pulmonary artery is dilated. Yeah, MPA. Okay, go ahead. Any other frames you have?
Yes, sir. The continuous wave Doppler at a tricuspid valve and a mitral valve level. The TR max PG is 58, and there is a dense triangular signal, MR signals.
Based on that signal of the TRZ, would you say RV function is normal or depressed?
RV function is depressed, sir.
Depressed because
Because
what is
of
your
what?
criteria?
Normally the rounded contour will become more triangular in
No. What is dp by dt of the
dp by
RV?
dt you have to take of the
dp by
tricuspid
dt of
spectral
the
flow.
RV. What is the normal RV dp by dt? You are aware of dp by dt? What is
Yes,
dp
sir.
by
Yes,
dt?
yes, sir.
What is it?
It's the time required for the pressure to drop by half.
What does d stand
No,
for?
no.
What does d stand for?
dp by dt is not that.
D, no, that's what I'm asking. What does D stand for? D is for delta.
The right
Delta.
change in pressure.
Delta P by delta T. Change of pressure over time.
The isovolumic phase.
So basically, dP by dt of the RV is normally is what?
Maybe around
Not
400.
maybe. No, you have to know the normal values. You can't do guesswork here.
400.
400.
More than 400.
It is more than 500. 500 millimeters of mercury per second. What is the normal dP by dt of the LV?
LV is this is 500 to 600, that one?
More than 1000. So the rate of rise of pressure, on the velocity triangle there of the tricuspid wall is quite steep. Okay. Is there any tricuspid stenosis there?
So the gradient is no, sir.
No, sir.
So what is your criteria to say tricuspid stenosis based on the Doppler?
5 to more than 2.
Sorry?
The mean gradient should be more than 2, sir.
No. Mean gradient can be elevated even in tricuspid regurgitation. What is the hallmark, hemodynamic
That
hallmark of
will say there is
stenosis? Atrioventricular valve stenosis. What is the hemodynamic criteria? You are aware of it or not aware of it?
end diastolic.
Anybody from the NIMS student panel? They are unusually silent. Okay, I think what Dr. Balchandra has said, unless you have end diastolic gradient, you cannot diagnose atrioventricular valve stenosis. Okay, go ahead. So what is the jet velocity here?
Is 3.8, sir.
3.5.
3.5.
3.8.
Okay.
3.8. Okay, go ahead.
These are the videos. There's a dilated LA and on the color.
You see that doming of the AML.
AML.
What is the AML dome? What is
Because of a significant pressure difference between LA and
Oh, come on, it
LA.
can't be.
Yes.
No.
Yes.
Significant pressure difference. That is not the why there is doming, why only there is fixation of the tip of the leaflet.
Actually, which part domes actually?
What is the echocardiographic or morphological abnormality of rheumatic valve disease, apart from thickening of the leaflets?
The AML and the restriction of the posterior mitral leaflets.
Because why the PML motion is restricted?
Rheumatic pathology is mainly in the commissures.
So, what is your evidence for commissural fusion? Echocardiographically.
So the doming is.
Somebody from NIMS, student panel from NIMS? Are they there or are they?
They are there.
Suggestion of commissural fusion.
Okay, I think basically you need to know this commissural fusion. Why does the PML move anteriorly in rheumatic wall disease? Basically because of commissural fusion. So
So you
it
could
is
have taken an M-mode and shown a paradoxical motion.
Yeah. Okay, go ahead. So how do you quantify the MR here? What are the parameters you take for quantification of MR by echo Doppler?
The area of the MR jet, sir, if it is more than 4,
Area of the MR jet.
jet.
So,
Eight.
no, no, no.
MR jet to area more
MR jet is 8 centimeters and 8 centimeters square, and the area ratio of MR with respect to LA, if it is
Okay.
more than 40%.
No, no, no. I think we should read the guidelines. It says qualitative criteria, semi-quantitative criteria, and quantitative criteria. What are the quantitative criteria for severe MR?
Effective regurgitant orifice area
Orifice, yeah.
Means how much?
more than 3.3.
Sorry? Speak out a bit loud.
More
than
than
0.4.
Just remember the rule 4, 5, 6, 7. 4 millimeter square is the effective regurgitant orifice area. 5 is 50% is the regurgitant fraction. 6 is 60 ml of regurgitant volume. 7 is vena contracta, 7 mm. So this rule of 4, 5, 6, 7 is easy to remember. 0.4 centimeter square is the effective regurgitant orifice.
Yeah.
Now in multivalvular heart disease, which parameter is going to reflect the severity of mitral regurgitation?
MR.
Candidate is there?
Yes.
If there is AR, MR.
Yeah, I think for the student's point of view, you need to remember that there are two parameters which are load independent. These are all, one is vena contracta, other one is effective regurgitant orifice.
area.
So these are load independent. Other parameters are load dependent. So in multivalvular heart disease, you take only EROA as the most definitive method of evaluating the severity. Okay, go ahead. Next, any other data?
So where is the VST patch you say is intact?
VST, there is some the basal septum. There is some difference in echo texture. So there is no discontinuity. So I think probably is a VSD patch.
No, I think the candidate knows the patient. That is the reason why
we can't call this a
he's
patch.
only harping on VSD right from the word go.
What about the atrial septum?
Septum
is not seen actually. It has not been shown.
This is another Flax view showing a color Doppler. There is a posteriorly directed MR jet, and another 4-chamber view showing a presence of MR.
No. Here you can see the interatrial septum.
You can see the interatrial septum, and possibly there is a defect. Because of that, T artifact is seen both sides.
Yes.
Okay. What about your comments on the IVC?
IVC is distended, sir, with less than 20% respiratory variation.
Distended? I'm not able to see the distension anyway.
Sir, sorry for the poor quality echo images, sir. The patient was very sick in function class 4, so I had to rush to the
Fine.
So this is the parasternal short axis view at mitral valve level, showing a probable cleft in the
Left.
AML.
Yeah.
Yes. Windscreen wiper appearance. So this is another. This is the another flax view showing a colored Doppler. There is a posteriorly directed MR jet, and another 4-chamber view showing a presence of MR and TR. Yes. Windscreen wiper appearance.
Right.
My final diagnosis, sir. Status post AV canal defect repair. Now with the cleft AML, severe MR, severe TR, severe PH in AF with fast ventricular rate in heart failure, NYHA functional class 4, no evidence of infective endocarditis, situs solitis levocardia, right pleural effusion and ascites.
What is this? Which stage of heart failure is this? You said heart failure, right?
So class
So
4.
you have to state this stage now. You have seen all the investigations.
Function class 4, sir.
No. Staging of the heart failure is
Heart failure.
different.
Oh,
A, B, C, D.
sir,
Cardiac shock unte
patient is a hypotension with the features of hypoperfusion.
No. That is what you are telling about is
Clinical.
cardiogenic shock. I'm talking about heart failure staging. Stage A, stage B,
ABCD.
stage
Okay, sir. Sir, stage D, sir.
D. It is not C. It is
D.
D. It is D. Stage C is asymptomatic. Okay. So what do you want to do now?
The patient is having, sir, severe MR and TR. So the cleft AML maybe can be repaired. So by when combined mitral valve and tricuspid valve repair can be done.
So obviously they have missed out the cleft in the first surgery.
First
Is that,
surgery.
That's what I said.
Yes, sir.
Yeah.
I have reviewed the old documents, sir. They have mentioned they have closed it with the sutures, but sure.
Okay.
Yeah, the moral of this case is that when you see, even nowadays, when you see the ASD, you don't you have to evaluate the mitral valve by echo properly using all the parameters. Otherwise, if you just go ahead and close ASD, this is what will happen. That MR will progress and patient will go into heart failure.
Okay, I think.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, both teams. I think we had a good session. Venu, sir?
Yes.
Right.
I think the discussion was very good. Most of the answers were given by the students, but it's a fairly tough case.
But I think one of the morals of this case is, if you know the answer, you are focused only on that diagnosis.
Yes.
You're not thinking of any other alternatives.
The discussion wise, I would have thought of basically a pre-tricuspid shunt rather than a post.
Yeah.
So once you know this,
this is what happens in the examination. Somebody leaks out the diagnosis for you, and then you are in trouble. Okay. Anyway, I think they have done a fairly good job keeping in consideration the complexity of the patient. But I think you need to know a bit more about echocardiographic data. Yeah. And then what are all the possibilities that can happen? I think it's not a straightforward case. It's a difficult case. Agreed. I think in the examination, getting the diagnosis is not important.
Exactly.
Rationalizing your answers is more important and relevant. Approach is more important than the actual diagnosis. Okay, I think they have done fair.
Yeah, very valuable messages. I hope all the delegates, all the participants are listening. Very useful case and very important messages by the examiners.
While presenting history also, you have to take into consideration modern. Like for example, ESCAPE trial has told about orthoedema. So you have to see how much pillows, 3-pillow orthopnea, etc. So all these things you have to mention clearly.
Yeah.
Okay, I think.
Yeah, thank you. Actually, I think I should congratulate the Rahira panel and the team from Kottayam for bringing up this case, which is indeed, I mean, worth a lot of clinical discussion and good work by the postgraduates, Dr. Chayed and Dr. Paramesh, for working it up and presenting it well. And good work done by the student panel from NIMS Hyderabad, Dr. Vinay, Dr. Sairam, and Dr. Veer. I should thank the examiners, Dr. Dayasagar Rao sir, Dr. Balagandar sir, and Dr. Rehinat ma'am for taking the discussion forward very well. And we had a good session from by Dr. Ravi Prasad Verma also on the concepts of randomization. So that's also an eloquent talk. So on behalf of the Heart Failure Association of India, this we come to the conclusion of the Heart Failure Masterclass for this year. And I think when we look back, we should thank Chopra sir, Abraham sir, Harishan sir, Venugopal sir, Dr. Sajan, and the entire team who actually made this into an international affair. And we thank our the Heart Failure Society of America for partnering with us this year and having joint sessions with them. I must place on record the support we've received from Sun Pharma Corona Division for getting the logistics and the work done by Vinay and the entire team from Hallmark, Sumita and others who have worked throughout the year for getting this thing done. So we all will get back next year with a little more exciting pattern, and it's a privilege for me on behalf of Harishan sir and the other organizers from Heart Failure Association of India to welcome you all to the upcoming national conference at Ahmedabad in February. And before that, we'll be having the Back to Basics session at Thiruvananthapuram in January as well. So the students can make use of the opportunities available. So thank you all. Good night and Merry Christmas and Happy New Year.
Very Happy New Year to all of you.
Oh, same.
We'll be meeting in only March. So,
so next will be in March sometime. Yeah.
Good night.
Good night.